For the next oral presentation is MEESSI-AHF score performance in predicting 30-day mortality among acute heart failure patients in emergency department of Nakornping Hospital, presented by Chitsanupong Maneerat from Medical Education Center, Nakornping Hospital.
Yes. Okay. Good morning, everyone. So my name is Chitsanupong Maneerat from the 5th medical student at the Nakornping Hospital Center and from the Phayao University. And today I will present about the MEESSI acute heart failure score predictive of 30-day mortality in acute heart failure patients at Nakornping Hospital Emergency Department. So let's begin. In the worldwide, acute heart failure is the most major problems that can occur to a lot of people and can cause the most mortality rate all the worldwide. So as you can see, as my poster show that almost 50% of patients are die and dead by acute heart failure and re-hospital in the 6 months. Yes. So in Thailand, the patients would have around 250,000 patients who have a cardiovascular underlying disease. And in the region 1, you can see the mortality rate about 5% per hour. Yes. And this in Nakornping, acute heart failure contributes significantly in patient mortality, and many patients are re-hospital too. Because of this high burden, we need an accuracy and latitude to predict a short-term mortality in emergency department. So let's begin. The MEESSI acute heart failure score is the multiple estimation of risk based on the emergency department Spanish score in the patient who present with acute heart failure. So this is a validation risk model from Spain to predict the 30-day mortality in acute heart failure by using 30 available factors, and that can calculate and categorize the patient for the 4 groups, just like low risk, intermediate risk, high risk, and very high risk, and mortality rates from 3.9% amount to 90%. Yes. So our team has an idea to take this score by using our environment and our hospital. So this is the objectives to the first one is to access the accuracies of MEESSI acute heart failure score and risk stratification with predicting a 30-day mortality from acute heart failure in emergency department. And the second one is the develop a new score that we call enhanced score. So this is the study design. So the first one, we have the populations with acute heart failure or diagnosis with acute heart failure with no STEMI and over 18 years of age who are admitted in the ED department and are IPD at the Nakornping Hospital. And we get our patient with 547 patients. And after excluding by this criteria, including surgical AHF, or SCA, or incomplete key data, we finally have the sample size is 347 patients and calculate the mortality rates. So finally we have the result that there were 23 patients who died and 324 patients who survived. So this is show the MEESSI score will perform very well in our populations. And this is show only the significant factor that can affect my patients. Yes. As you can see, the S1 is the low oxygen synthesis, and the New York Heart Association functional class 4 and low vital index score and a low cardiac output symptom. Yes. So this is show the ROC curve of the MEESSI score that can predict well to discrimination of my patients, and also show the good calibrations and good discrimination of the MEESSI score too. So from the top, we also know the MEESSI score may require the 30 factor to use to calculate the mortality rate, but in Nakornping Hospital, that's what a lot of time to use it. So we use the enhanced score that from the 3 factors that can most strongest affect with our environmental. There's component by low Bartel index at admissions, New York Heart Association cut flow, and low cardiac output symptom. So this is the mortality rate from the enhanced score that can calculate it from the patient who present with. So this is the comparing between the MEESSI acute heart failure score and the enhanced score. This is the p-value is 0.271. That means the two score was not different. That means I can use this score instead the MEESSI heart failure score too. So, and also good calibration and good discrimination too. So this is my discussions. The MEESSI acute heart failure score is demonstrated good with stratification in this setting, but not may require 30 factors to calculate this. But the Nakornping or the enhanced score can calculate it too by use only 3 factors to use it. It's a good predictable too. And this is conclusions. The MEESSI-AHF score is predict 30-day mortality by using 30 factor available, but we don't need to use it. We use only a 3 factor to calculate it can do. So this is my future clinical implications. We have to use the MEESSI acute heart failure score or enhanced score to improve ED triage and resource use. The long-term or prospective study to improve their expectations and the result supports and to guide the patient should be admitted to the critical or medical ward or why a low-risk patient may discharge or observe if stable. Yes. Thank you for your attention and thank you.
The mortality rate is only the death from the cardiovascular disease only or all?
In my paper, we use a death mortality from the heart failure, only heart failure, yes. But we excluding some other types of the heart failure, such as cardiac hospital cardiac arrest or non-STEMI, yes. So in these patients, that means we use the only acute heart failure or acute heart failure symptom too, not by only diagnosis.
In your opinion, the new score, what is the benefit of the new score for you?
Thank you for your questions. The new score, the enhanced score is not different from the MEESSI score. So we can use this score to predictive 30-day mortality too. In my opinion, there's words usefulness for the small hospital or rapid, more practically and more easy to use to assess the one patient who come in the ER, and when the doctor wanna access the patient very quickly because of a lot of patients who comes and we don't have the time to assess the patient by only yes, and the enhanced score will use only the 3 factors, yes, and they can assess quickly more.
I think that the NHEART score is very interesting because they're just like only 3, right? I just wonder like how did you choose like the factor from the MEESSI one into 3 that is going to be suitable for the NHEART score?
Okay, thank you for your questions. The NHEART score, why that I choose this? Because of in my results, at the final results, we found that the MEESSI score has some factor, but not all factor that have a strongest factor. So we use this strongest factor to calculate this my new score and validate the score. And finally we found there's not no difference between, yes.
So we should stop using the pro BNT, right?
Yes.
Because it's very expensive, and the patient who come to the ED with the clinical of heart failure is very easy to diagnose, and I think every hospital try to send the pro BNT to confirm the heart failure, and your study found that it's not benefit for predict the survival of the patient. Right. So how do you plan to use this enhanced score in your ED?
Because of
For example, if we found that this patient have low score and they have a high survival in 30 days, you can discharge them. Or if they have a high score, you cannot discharge them, for example.
It depends on the severity, yes. But so in my opinions, that patient who have a low score that may be discharged or observed, but the intermediate, a very high or a high score, that should be guided to admit to the each other ward in her hospital, just like the IPD or the CCU or the ICU or something like that. So thank you.
Thank you for a captivating topic.